Fellows Case Corner sessions have been one of the major attractions of Pakistan Live for like 3 to 4 last Pakistan Lives. So, after our experience of last year, we brought in some major improvements. We simplified our case submission system, where candidates took just 2-3 minutes to upload their case. It was very easy. Nobody just contacted me that they had any trouble at all. And we got 118 cases at our portal, 3 of which were from abroad for the first time. We received 2 cases from UK and 1 from Turkey this time. And these cases were then sent to a list of reviewers from Pakistan and abroad. So we had got like 48 reviewers to whom the cases were sent. And the process of sending was very simplified. They just received a simple email in which all the instructions were written how to assess the cases. And they had just to click on a link shown here, like in the blue segment. Okay. And then they would just click on the link, and this screen would appear where they could just download the case and mark some score to them. Okay. So once they were done with the scores, this was the backup screen where we received all the scores from all the presenters. We had all the data that who submitted the case, from where did the case come, all the contact details and the scores from the respective scorers. On the basis of this, we selected 30 top scorers who were then communicated that their cases will be presented in the conference. And then they presented their cases in the conference, and the sessions were very well attended. They were very interesting cases. And this time we brought up another new thing, that the panelists of each session were given this sort of scoring form on which they actually scored each presenter, and the average was taken. And on the basis of this, we were able to select the 4 best cases. And these are those 4 best cases, and we are going to hear from them briefly right now. So I would like to invite Dr. Khalil Ahmed to present his case of double disaster. गिर जाएगा.
Assalamu alaikum. I'm Dr. Khalil, and I'm from NICVD. I'm here to present a case with title of dual disaster intervention, coronary intervention. So my patient, 37 years gentleman, presented with typical chest pain, and he was diagnosed as acute coronary syndrome. And at that time, he was shifted to cath lab immediately. You can appreciate the right coronary system is non-obstructive, and the severe disease from ostial left main extending to the LAT. So at that time, it was decided to do the PCI from left main to LAD. You can appreciate here, it is severe disease from ostial left main extending to the LAD and stenting from the ostial left main to the LAD, done successfully. You can see here the result, and it was post-dilated. And patient smoothly discharged on medical therapy. After a couple of months of the PCI, he developed typical chest pain on exertion. Multiple times he visited to clinic with typical symptoms. We optimized his medical therapy. Despite of medical therapy, he has worsening chest pain. That's why we decided to take him to the cath lab again after the 1 year. So you can see here, you people can appreciate that the ostial circumflex is severely diseased. At that time, we planned to do the PCI of this ostial circumflex. As you people can appreciate that there is a stent from left main to LAD which was implanted 1 year back. So we pre-dilated this lesion with 2010 balloon, and after that, we tried to cross the stent from this old stent to put it into the ostial circumflex. But unfortunately, it was not crossing. Then we tried to change our guide for the support. Still, it was not crossing. Then we changed the guider from EBU 35 to L. Still, it was not crossing. After that, we were decided to take the EBU 40 guide for the maximum support. Then we decided to remove the L guide along with coronary wire and stent, which was already we were trying. So when we removed the whole system, the guide, wire, as well as the stent, at that time, we checked the stent that there was only balloon and stent was not mounted over that. So we were actually searching that stent over the table that we could not find it. Then we did the fluoro from head to toe of the patient. Then fortunately we found that stent has been dislodged in the ground. After that, we took the EBU 40 guide, and again we tried to cross the stent. Unfortunately, we could not cross again. And it was found that second stent was again dislodged. And this time, this stent was dislodged within the old left main stent. You can appreciate here just their single dot of the balloon. You can see here, and in the left main stent, the new dislodged stent is hanging. You can see here. After that, we removed the circumflex wire and we put it into the LED and we entangled these wires and we decided to retrieve this stent and we removed this whole system. And after that, we planned that we are deferring this procedure right now. But at that time, when we removed the system, patient developed typical chest pain. And that time, we decided to do just diagnostic view with the JL catheter. You can see here, this is the dislodged stent in the left main. And this is the diagnostic shot with the JL catheter. You can see here, what is this? You can look at here that the left main stent, which was implanted 1 year back, which is completely endothelialized, has been extracted totally. Then patient becomes symptomatic, he becomes unstable. You can look at here, whole stent which was implanted 1 year back was extracted with the whole endothelium. You can look at this. So at that time, we forget the circumflex as it, and we cross the wire into the LED, and we put a stent in the mid LED as well as left band to LED. So you can look at here, and it was post-dilated. This is the final result. So the take-home message is that if you are doing good, you can bring here such cases for the discussion. And if you are not doing good and something happening like this, still you have to bring such type of cases because this is the conference. We are here to learn from each other. So this is the take-home message. Don't hide such type of complication. You have the courage to come here and bring such type of cases so that we can learn from each other. Thank you very much.
Thank you, Dr. Khalil. It was very brave of you to share such a case with the audience, and we learn like this. Next, I would like to call upon Dr. Muhammad Ishaq from PAC Peshawar, and he'll present his case about first national case of ultra-low contrast PCI.
Thank you. I welcome you all. I'm Dr. Muhammad Ishaq Khan from Bashir Institute of Cardiology. So our case was an 82-year-old lady who presented to us with acute coronary syndrome with diabetes, hypertension, and family history of ischemic heart disease. She was on presentation in CLIP class 2. This was her ECG. I'm sorry for the distortions here. The echo was 35 to 40% of LV. This is her diagnostic angiogram. You can see a lot of calcium in the left anterior descending artery and significant disease. It was a right dominant system. So after the angiogram, her creatinine went from upper normal up to 2.2 to 2.3 in the next 3-4 days. As it was discussed in the HERT team, she was denied by the surgeon for high surgical risk. So now we were left with a surgical decline frail lady. She was in pain. And either we do nothing, we do give her only medications, or leave her on medications, or go for PCI for the procedure. So after discussing with the family and the patient, we went for the procedure with as much low contrast as possible. Initially, we planned for zero contrast, which could not happen, but the literature which we searched, we come across a lot of cases since 2005. These cases have been operated upon, and in several case reports and several studies have been published now, and these Japanese studies are now coming up with almost 1 year of follow-up. And in this study down on the right side, almost 100 patients were included, and now they've come up with 1 year follow-up, and they've shown that induction of renal replacement therapy was 2.7% as compared to 13.6%, which is a great difference based on the low contrast. In this landmark paper by Dr. Brown in 2010, he included almost 10,000 patients, and he explained the term of MACD, maximum allowable contrast dose, which can be calculated for every patient, and even if with normal EGFRs, which can be calculated by dividing the volume of the dose of the contrast divided by the EGFR. If the ratio remains up to 1 or less than 1, so you are fine with using that much of contrast. So now we started the procedure and took femoral root and skeletonized the main vessels, the LAD and the left circumflex. Took the IVUS run down the LAD. This is the IVUS run. You can see a lot of calcium in there, around 270 degrees, and in some areas up to almost 360 degrees of calcium. It is a trimmed image for the sake of time. Then we tried to expand the balloon, NC balloon, which did not expand. You can see the dog boning effect over here. So we decided to go for the rota. After rotablation, we did another IVUS run. These are still images. You can see a lot of calcium cracking in there. Then we placed 2 stents from mid to proximal LAD, and followed by an Onyx 3.5 post-dilated with 4.5 NC in the left main to proximal LAD. And these are the final result. And this single shot was taken after the procedure. And post-IVUS run was also done. Post-PCI IVUS run. Yes. These are take-home messages I would like to share, that ultra-low contrast PCI is possible and relatively safe in patients who get deferred for their CKDs and increased creatinines. Use of IVUS and rotablation should be used more frequently to get our fellows acquainted with these gadgets. FFR can be done instead of contrast injection. It can be a bone of contention between protagonist and antagonist, but there are cases reported who have followed the patients with repeated echoes, not even doing a single contrast. So they went with zero contrast. And FFR can be done after the PCI to show that there is no significant lesion left, and even the single shot can be diminished. Thank you.
Thank you, Dr. Ishaq. It was a wonderful approach that you took. Next, I would like to call Dr. Syed Ali Shiram from AFIC, who's going to present percutaneous intervention of a leaking vein graft pseudoaneurysm.
Bismillah ar-Rahman ar-Rahim. Good morning, everybody. I feel honored to speak in front of this august gathering. Today, I'll be presenting this unique case of percutaneous intervention of a leaking vein graft pseudoaneurysm. So, this is a story of a 63-year-old man with a history of triple vessel coronary artery disease who had undergone bypass grafting in 2019. Now he presented to us with complaints of recurrent episodes of heavy bleeding from a sinus in the lower one-third of the chest, for which he was initially managed with blood products. When he presented to us, his clinical examination was unremarkable, except for the draining sinus at the lower one-third of the sternotomy wound. His biochemical and coagulation profile were normal, except for the hemoglobin of 12 gram per deciliter. So on the left side, you can see the draining sinus in the lower one-third of the chest. That was the source of bleeding. And on the right side, you can see this huge pseudoaneurysm at the distal end of at the insertion point of SVG to PDA, which was connected to the draining sinus through a fistula. The coronary angiogram confirmed this humongous pseudoaneurysm at the distal end of SVG to PDA. This measured about 19 into 20 millimeter. So the case was discussed in heart team meeting and it was decided to percutaneously close the aneurysm using cover stent, since the surgical option carried the increased perioperative risk of mortality and bleeding. So after taking femoral access, we took the 7-front multipurpose guide and the run-through guide wire along with fine cross to traverse across the pseudoaneurysm. However, the wire took a loop inside the pseudoaneurysm, and while maneuvering the fine cross across the wire, there was another loop proximally. And while we were doing these maneuvers, everything was thrown out. So we had to renegotiate the pseudoaneurysm with the help of the fine cross, and this time we replaced the run-through wire with a more supporting wire, and that was the Grand Slam wire. The dilemma was that there was a huge loop in the pseudoaneurysm. Even the fine cross took the loop, so we decided to take the anchoring balloon and inflate it distally, and we took a guide liner to negotiate across the pseudoaneurysm. And after a lot of effort, we were finally successful to straighten the loop of the wire in the pseudoaneurysm, as you can see in this clip. So this maneuver did wonders for us. So then the anchoring balloon and the guide liner were removed. And this is the picture with the loop straightened inside across the pseudoaneurysm. We then took a stent, of 3.5 into 20 millimeter covered stent PK papyrus, hoping that it will, cover the whole area of pseudoaneurysm. The stent was being deployed, but after that, there was still leakage from the distal edge of the pseudoaneurysm. We then post-dilated this with the 4 into 10 millimeter non-compliant balloon, but the leakage was still persistent from the distal edge. So then we decided to take another stent that, again, this was a cover stent, this time of bigger size. This was a 4 into 16 millimeter cover stent to cover the distal end of the pseudoaneurysm. The stent is being positioned and it's being deployed at the distal end, overlapping with the proximal stent. And after that, there was still mild leakage from the distal edge. We then again post-dilated it with another 4 into 12 millimeter non-compliant balloon, post-dilating the overlapping part as well. And this is the final picture. It showed complete occlusion of that gigantic pseudoaneurysm. A few words about the SVG pseudoaneurysm. It's a very rare complication. The fistulas occur in 7.7% and can cause sudden death as well. RC is the most common size and the treatment options are as flashed, including the cover stent. And only few cases have been reported across the globe, and this is probably the first case from Pakistan that used the PK papyrus stent to close this huge pseudoaneurysm. So the take-home message is the pseudoaneurysm, it's a rare complication but can be life-threatening and can cause heavy bleeding. So timely diagnosis is essential and management percutaneous Although challenging, it's a very viable alternative to surgery and can be life-saving. I thank you all for your patient listening.
Thank you, Dr. Saghir Ali Shiram. Very well done. So next, I would like to call upon Dr. Amna Farooq Janjua from Liaquat National Hospital, Karachi, and she is going to talk about a case of complex PCI or left main disease.
Good afternoon, everyone. My name is Amna Farooq Janjua. I'm a cardiology resident at Liaquat National Hospital, Karachi. My case is about a left main disease, which is a common clinical entity, yet management of left main disease in acute clinical setting continues to pose a clinical dilemma and apprehension in clinical settings. I'll start off with my case encounter. Our patient was a 75-year-old diabetic hypertensive male, a known COPD with an active smoking history of 39 pack years. He presented to our ER at 4:30 a.m. with the complaints of central typical chest pain associated with profuse diaphoresis and progressively worsening shortness of breath at 4:30 a.m. The family brought him to the ER. At presentation in the ER, the patient was not hemodynamically stable. He had a thready pulse. He was desaturating, and his blood pressure was also low. So this was the ECG done in the ER. As you can see, it's LVB, but we did not have an older record to compare it with. So we did a bedside echo, which showed severe LV dysfunction globally. Based on this, we diagnosed the patient as a case of ST elevation MI equivalent with cardiogenic shock. The patient was given initial management in the ER, and after that he was moved to the cath lab, where his left heart cath was done via right femoral approach. Upon engagement of the right system, we noticed significant pressure dampening, which also indicates an ostial lesion of around 90%. On engagement of the left system, we recognized that the patient had severe calcific left main disease with a distal left main lesion of around 90%, but rest of the vessels did not show any obstructive lesion. Based on the angiogram, we took a heart team approach. We calculated patient syntax, which favored PCI over CABG. So we decided that we'll proceed with PCI, but we had to strategically plan our case. The patient was in cardiogenic shock, so we went with LV support device. We inserted IABP. We decided that we'd start off with RCA ostium because then we'd have better support for left main. And finally, we decided on going ahead with provisional stenting because the patient was not in a clinically very stable state for prolonged procedure. Starting off with the PCI of RCA, it was pretty standard. We pre-dilated it with 2.510 SC, followed by stenting it with 3013 Zions expedition, which was followed by post-dilating it, and these were the results. Next, we started off with left main to LAD. We wired both the vessels. We pre-dilated left main to LAD with 2.510 SC, but it had inadequate results, so we then further pre-dilated it with 3.58 NC. When you put in the stent 3.533 Zions expedition, the wire from circ had actually come out. But patient had started running ill-sustained VT at this point, so we continued with the procedure. We post-dilated it with 4.58 NC balloon, but then the circ had gotten occluded. So we quickly tried to rewire circ. It fortunately went through easily. We did kissing balloon inflation of both the vessels, followed by proximal optimization, and these were the final results. We did realize that the circ ostium had been pinched, but since it wasn't flow limiting, so we called the procedure done, and we moved the patient to the ICU. He remained on IBP and ventilatory support for the next 48 hours. He came off it 48 hours later. He was discharged on the 5th day of admission after reassessing his LV function, which had actually improved. He followed us up 2 weeks later with improved functional class and no residual symptoms, highlighting the fact, which is today's actually my take-home message, that PCI does offer a more expeditious and rapid recovery in appropriately selected patients with left main disease. I thank you all for your patient listening.
Thank you, Dr. Amna. Next, I would like to request Dr. Bashir Hanif to reflect upon the Pakistan Live 2022. Sir. So before that, we are going to announce the prizes for the best fellows And I would call them in sequence. So just a minute. Number 1, number 4 ना बन जाए जरा देख लें. जी. So in the reverse order, I would like to announce the winner of 4th best case is Dr. Khalil Ahmed from NICVD, and I would like to request Professor Zubair Akram, the President-elect, to give him the award. Okay. And I would also like to call upon the representative from the High Q to come upon the stage because they sponsored the event.
So Dr. Khalil gets 50,000 cash prize for his presentation. It is number 4.
Next award will be given by General Kiani Saab, sir, please. And the award winner for the 3rd best case is Dr. Muhammad Ishaq from PAC Peshawar. He'll be awarded with a prize money of 75,000 Pakistan rupees. Next prize award will be given by the President of PSIC, Professor Nadeem Rizvi Saab, and the award winner for the 2nd best case is Sayyid Ali Shiram from AFIC. And the prize money is 100,000 Pakistan rupees. And the award and the prize of the best case will be announced by the course director, Dr. Bashir Hanif. And this award for the best case of Pakistan Live 2022 goes to Dr. Amna Janjua.
Okay, so the best prize this time, we decided that we were able to achieve one fellow to send to Society of Cardiovascular Angiography and Intervention fellows course, which is going to be held in Miami, Florida from December 2 to 6. So all the expenses will be paid by the society, Pakistan Society of Interventional Cardiology and SKY for this fellows course. And this is going to be a huge thing. First time ever, a Pakistani fellow will be sent over there. And this is going to cover the registration as well as the hotel stay and the return ticket from there. So it's going to be much more than what it's going to be.
Congratulations, Dr. Amna. Would you like to say something? Sure.
So thank you very much. It was an absolutely delight to be here and to present case in front of such a learned audience. And thank you very much. That's it.
Next, I would like to call Dr. Bashir Hanif to reflect upon Pakistan Live 2022. Sir.
Thank you, Arslan. So I think now I can have a sigh of relief and relax. This is the journey which we really started a few months ago, and it's been a day and night journey. Believe me, lot of hard work from a lot of people have gone into it. And overall, if we look back for Pakistan Live, starting from 2016, I think we have made a lot of progress. And Alhamdulillah, I think contribution from all of you. Some of them are putting less, some more, but that's how things work. और कुछ की लोग हैं जो कि आगे आके साथ हेल्प कर रहे होते हैं और बाकी just all of you being here, giving talks, other panelists, chairpersons, moderators, obviously there's a contribution from all of you. This year, as you have seen, we have done a lot of new things, and inshallah, every year things are going to get better. Definitely, nothing is perfect, और इस साल भी कुछ issues हुए हैं, for which, on behalf of Council and the Scientific Committee, if there has been any inconvenience or discomfort, we are sorry for that. I know there were some issues in the rooms initially, but inshallah next time we'll make sure this doesn't happen. But I would request all of you to look at the positive things and forget about the negative things. And I think the positive things which we have achieved this year, first of all, it was the app for the scientific program for Pakistan Live, first time launched. Inshallah, this is going to improve next year. A lot of effort was put into it by Arslan and a few other colleagues as well. And secondly, I think the cases, previously there has been a lot of problem. This year the cases were submitted online, was sent to all the reviewers online, and they were able to review it online and mark it online and send it back to us, and we were able to see all those cases. And out of those 25 cases, I think Arslan forgot to mention how we decided the first 4 cases. Actually, when they were presented, all the moderators who were sitting there, which were like 8 people sitting there, panelists, who were given that form to basically mark them. And out of those 25, then the highest marks, whoever achieved, those were given these awards today. And I would encourage all of you to encourage your trainees and fellows to be able to come and present here. It's not only for encouragement, but it's for them as a practice to speak up in later on in international forums as well as national forums. So all of us should be encouraging, and I'm hoping every year the number of cases submitted are increasing. I'm sure with the very kind of a handsome prizes this year, awards this year, hopefully the next years we will have more cases. And there will be a lot of new things, inshallah, coming up. This year, I think learning sessions and hands-on training was, again, very popular and very well received. We are going to definitely improve on that. We focus mostly on the live cases again. I think from last year, the live case transmissions has improved, but definitely we need to work on that to improve further, and inshallah, we will do that. Most of the talks, we try to do kind of a practical case-based so that really we talk about what we see every day in our cath labs, not like kind of a routine lectures which are given and then forgotten. So mostly they were case-based, and I hope this you are going to like it. We would have something online available soon, which is like we would like your feedback. Any suggestions regarding improvement, any negative or positive criticism will be welcome, and we'll try to improve. If you have any suggestions for new sessions, any new topics you want for next year, so please do give those suggestions online. And again, this year, I think all the talks, all the cases which has been done throughout these 3 days will be available online, inshallah, within a couple of weeks. So you will be able to go on our website of Pakistan Society of Interventional Cardiology, and will be available to, you can review by day, by cases and everything. So that's again going to be another new thing, and it's going to be a huge educational activity for all of us. So I hope overall all of you enjoyed and learned as I did. Every time I'm here, I learn new things, and we hope that you learn it also. Thank you very much for being here. And I next year, inshallah, will see you in Lahore. The plan is it's going to be in March or April. We have to just decide in the council whether it's going to be before Ramadan or after Eid. So we will decide shortly and communicate to you. And obviously, if it is in March, we have only 6-7 months. We have to start working from now. Dr. Tahir Saghir is going to be thanking individually later on to everyone, but I really want to thank Orbit's team who have really worked day and night with us. Owas and all his team, Zohaib was running all the time for live case transmissions. It's not an easy task to coordinate internationally and nationally in different areas. As I said, nothing is perfect. There is always a room for improvement, and we will do. But I think overall they did an excellent job, and I really appreciate and give a big hand to all his team. Thank you very much. And similarly, all pharma industry, without their help, obviously this is not possible. And thank you very much once again for being here, and hope to see you next year, inshallah, in Lahore.
Next, I will request Professor Nadeem Rizvi, the President of PSIC, to address the session.
Assalamu alaikum ji. I'll just take a couple of minutes. I think this is my own personal thinking has always been that the responsibility, authority and privilege should lie in a singular domain. And in our council and under my presidency for the last 1.5 years, this is what we've tried to do. This is the first time where the president is not one of the post directors. And what that has led to is that once you delegate and empower the right people for the right job, then things improve. And I think that's what's happened in our council this year, and I hope that this will continue. The academic committee headed by Dr. Numan Nasir has done an excellent job with all these CAT conferences, and I would encourage you to keep a record of these cases that you do worldwide, in all over Pakistan, and then one can actually have a live inbox or those cases presented here as well and maybe selected. The digitalization is extremely important in the educational part that we should have, as Dr. Bashir has mentioned. Lastly but not least, I think Dr. Bashir has done a wonderful job. The only issue that I have with Dr. Bashir is he just takes too much on, and then, I think he's a very senior and a very accomplished academician, and I think what he needs to do now is to pick up a few of your fellows from all over the country and make them do the scud work that he's been doing himself for this conference, in addition to Arslan and Tahir Saghir. Amber was the third course director, but she unfortunately was not well. So in the end, I think this was an excellent meeting, and I would like to thank everyone involved, including the Orbit people and the rest of them, the council and the foreign faculty. And I would just request the foreign faculty to ensure and advertise this Pakistan Live, and I think on March and April we would have even a better conference. Thank you very much.
Is Dr. Tahir Saghir here? Yes. Oh, okay. I was trying to call you. I didn't see you, so I was worried.
We are finding it difficult to locate you. So we request Professor Tahir Saghir to close the session by giving the vote of thanks to everybody.
Thank you.
ताहिर की आज की एक्सरसाइज थी उधर से यहाँ आना ना, that's his daily exercise.
अभी जाके फिर एक लस्सी पीऊंगा. So, after such a marvelous event, I would now like to thank the international faculty who come to Pakistan all the way to do cases and taught us the techniques and train our young fellows. That include Professor Umar Godkin and his team from Turkey, Dr. Rosalie from Malaysia, and Professor Chen with his team from China, along with Tanveer Rab, Sohail Khan. Then I also thank international faculty who did the virtual cases from abroad, and also the international faculty who have talks and discussion in our cases, that is Ehtisham Mahmood, Bilal Murad, Salman Arai, Naeem Tahir Kheli, Rajiv Johar, and Javed Salman from USA, and from UK, Mohammad Engred and Javed Ahmed, from China, Professor Wu, and from Singapore, Fahim Jafri. I would also like to thank our senior faculty in Pakistan and also the other colleagues. They all come from their hometown to Islamabad to attend this event. And also thank FIC and RIC for organizing the live cases from their labs. I would also thank Dr. Najib Azam from England, who was in WAB. And Sohail Khan, I have already given his name in the UK, and involved in the academic activity. I also thank the Academic Council and the Scientific Committee, the course directors and associate course director, and the secretarial staff for organizing this event. I think I have already thanked Dr. Tanveer from USA. The most important thing that without our pharma and industry, device industry, we wouldn't have been able to organize such a large event. And I now thanks Medtronic, Ferozens, Farmivo, Getz, HiQ, Hilton, Tabros, Wilson, and almost 20 companies for their involvement in this gala event. In the last, now I will thank Orbit for organizing this event. They, from the day one, they are involved in our this Park Life, and they organize. There is some problem on the day one, but that was part of our conference. There has to be some problem. Then we pick up the warm-up and pick up the pace to organize and do the event. In the last, I would say that as this event is now closing, we will hope that you people take time and to attend our next Pakistan Live, and for that I will request all the major institutes and hospitals to send their cases, interesting cases, not their best cases, but their worst cases also, so that we have a better selection of the cases in the next year. And hopefully next year this SKY scholarship will be extended, hopefully maybe 2 or 3 or further added, so that we encourage our young colleagues to. I thank you all.
Okay, so with that, I think we would like to end the Pakistan Live 2022. Thank you all once again. Really appreciate it for everyone being here.